in Baylor College of Medicine in Pulmonary Critical Care. Dr. Howard graduated medical school from Texas A&M, then went on to do residency in Duke University, after which he worked as an epidemiological officer with CDC for several years before joining fellowship in pulmonary critical care at Baylor College of Medicine. He's also the medical director of respiratory care and has been taking care of the current pandemic, managing many patients at Baylor St. Luke's Medical Center. Dr. Howard?
Yes, can you hear me?
Yeah, we can hear you.
Okay, I'm going to share my screen right now.
We can't see you, but we can hear you.
I apologize, my internet went out. I'm actually working through a hotspot right now.
That's okay. Thanks for being here. We can see some screen on from you.
Yeah, I apologize. For some reason, the share screen is having a hard time. Well, Dr. Guntupalli, I apologize to everyone. We're having a hard time with sharing screen.
I can go to Dr. Randy Curtis.
Yeah, that'll be fine.
Randy, okay?
Yeah, sure.
Okay.
Ravi, can you help Dr. Howard with the slides? Maybe you can run his slides on the side.
Yeah, Dr. Randy Curtis, it's my great pleasure to introduce him. He's a professor at University of Washington School of Medicine. He's a director of Cambia Palliative Care Center of Excellence. He's very well known in this area of palliative care, and he's one of the authors of very well-known methods of communication with the families of critically ill patients called Value System. And he was also a past president of American Thoracic Society. Randy?
Great, thank you, Kay. So you can see my slides?
Yes, we can see.
Great. So I'm going to spend about 10 minutes just talking a little bit about palliative care in the time of COVID-19, and particularly focusing on caring for patients with acute respiratory failure. I don't have any financial conflicts of interest to disclose. I do like to acknowledge the funding sources for our programs, including our healthcare system, UW-Medicine, the Cambia Health Foundation, as well as the NIH and PCORI. So what I thought I'd do is talk a little bit about the importance of advanced care planning and goals of care discussions in the context of providing care for patients with chronic illness as well as serious acute illness, and then talk about what the modifications we need to make for the COVID-19 pandemic, and spend a little bit of time talking about our experience in delivering palliative care during the COVID-19 pandemic for patients as well as their families. First of all, a little bit about how I use some of these terms. I use advanced care planning to refer to the broader scope of talking about values, goals, and preferences for future care. And that can apply to healthy individuals as well as, individuals with illness. And goals of care discussions, I refer to as the component of that for patients who have a serious illness. And we're talking not about future care so much, certainly not distant future care, but more immediate and short-term care. And you can think of, I think of goals of care conversations as being early goals of care conversations for patients with chronic illness, but who are not imminently dying, as well as late goals of care discussions for patients who are imminently dying. And I think that for patients admitted to the hospital with COVID-19, even if they're doing well, I think it's important to think about these early goals of care discussions. In terms of providing palliative care, I think it's important to highlight the broad domains that go into palliative care, including physical and psychological symptoms, communication, but also coordination of care and assessing spiritual needs and providing spiritual care. And I think it's important to think about this in the context of primary palliative care, which is the care provided by all clinicians caring for patients with serious illness, including in the ICU, the intensivists, the ICU nurses, social workers, and others. And then specialty palliative care, specifically care provided by palliative care specialists. And I think an important part of providing high quality palliative care is to figure out the mix, the right mix for each individual context of primary palliative care and specialty palliative care. So with that as a little quick overview of how I think about these terms, what are the changes that we need to make in the context of COVID-19? What's really different about our fundamental approach? And I would argue nothing, that COVID-19 increases the importance of these issues, but really our basic approach, at least as we experienced the pandemic in Seattle, was pretty much the same as it always had been. Now, I would argue that things would have been different if we had hit crisis standards of care. In Seattle, we were lucky we did not hit crisis standards of care. I think they would be different in that context. And I think it's important to think about these three levels of care. Conventional care, the care we were providing last fall or last summer. Contingency care, where we're striving for usual care under stress. And that certainly was the experience in Seattle during the COVID-19. We were definitely providing contingency standards of care. But we didn't hit crisis where there are scarce resources that require triage and limiting of indicated care. So we were not in the crisis standards. We were able to avoid that through public health measures, social distancing, wearing masks, closing schools, shutting down elective procedures, for example. If we were to hit crisis standards of care, then hospital triage teams, what we decided and what many places are doing is developing hospital triage teams that would make allocation decisions. The crisis standards of care should be applied across an entire region, not a single hospital. And under those contexts, decisions like use of CPR, for example, may be included in those triage team decisions. So we wrote this piece about the importance of advanced care planning and talking about do not resuscitate orders during this pandemic. I think this pandemic, certainly when we were under times of stress, heightened the importance of having these discussions with patients and their families, heightened the importance of using our palliative care specialists to teach, coach, and support those of us on the front lines providing this care. And we also talked a little bit in this article about the idea of informed assent. And I do want to touch on that a little bit because I found that helpful in some patients, for some patients and families during this context. I think the idea of informed assent comes up particularly around thinking about CPR, that non-beneficial or unwanted CPR has always had risk for patients and families. It can prolong patient suffering and increase family distress. But I think during COVID-19, that's particularly true, and there may be increased risk for clinicians as well, increased potential for exposure, increased clinician distress, and increased use of what was at one time, not currently, limited personal protective equipment resources. It's also important to acknowledge that CPR is going to be less effective for an in-hospital arrest for a patient who's in airborne isolation for COVID-19 because of the time that it would take the ACLS team to get in and don PPE. And in this context, we thought that this idea of informed assent was an issue worth raising. This was something we published back in 2007 in CHEST, where we made the argument that we need not always discuss therapies that are not indicated. We don't have to discuss necessarily ECMO for a patient for whom ECMO is not indicated, or surgery. But CPR is an exception because of patient and family expectations. And so I would argue we do need to discuss that. Patients and families may be trained in CPR. And so it's important to talk about that. And informed assent can be an ethical option, particularly helpful for some patients and families who really can't take responsibility for a decision to forego CPR, but will let doctors decide. And in that context, I think informed assent can be helpful. So the idea behind that is first we assess the patient's values. Very few of our patients are true vitalists where they would say life is worth living regardless of its quality. If they are vitalists, I would argue informed assent doesn't apply. But if they're not vitalists, then this can be an approach where we describe CPR, we explain why CPR won't achieve the patient's goals, and then use an assent statement. In this situation, we don't use CPR. Do you understand that? And we don't say, is that okay with you? We don't say, do we have your permission or your consent to forego CPR, but rather just allow for assent, assess for understanding, and importantly, allow for objection. Some, rare, but some patients and families may object to that. And in that situation, we do not proceed with informed assent or a DNR order. If for those few patients and families who are true vitalists, I would argue informed assent isn't appropriate. There may be situations under which we would say that CPR is medically futile. I think that's very rare, but it is something to consider a unilateral DNR. But in general, informed assent wouldn't apply in that situation. And then I'll just finish up by talking a little bit about our experience with palliative care during the COVID-19 pandemic. In particular, I think supporting families was really important and a challenge. I think it's important not to underestimate the stress that the restricted visitation puts on patients, families, and clinicians. We really had to work hard to try to support all three of those groups. We spent a lot of time identifying alternative ways to communicate. We would make daily phone calls. The team would make daily phone calls from the ICU to every family every day. And so would the nurse, so they would have multiple phone calls. And we also would do video conferences, both with the team, but also allowing the family to see the patient. We did, despite the restrictions, also create opportunities for families to see patients through a window into the room, and even for patients who were at high risk of dying, we would allow 1 to 2 family members in to the room in personal protective equipment. We created this initial response plan for the COVID-19 pandemic for our healthcare system that really laid out, this is the example for the ICU, laid out how the palliative care team would support the ICU team, both in conventional capacity and contingency capacity, as well as crisis capacity, laying out the different roles and prioritizing certain patients, in particular prioritizing high need patients and families, excuse me, which includes the COVID-19 patients, and particularly focused on the ICU and the emergency department. The palliative care team was available for coaching as well as brief and full consults. And we developed an explicit plan for surge staffing. The key target areas of need were difficult goals of care discussions and code status discussions, as well as moderate to severe symptoms and spiritual assessment and support, and also in supporting families around the restrictions on visitation. We also developed this prognostic communication tool, which I won't go through in the interest of time, but really helping clinicians understand prognosis for patients with respiratory failure from COVID-19 to make sure that there was some consistency in how we communicated this. There are a number of resources that I want to highlight as I wrap up here. There's this wonderful website from the Vital Talk group that has COVID-ready communication skills that I would commend to you. And there are also important resources for patients and families, as well as our friends and relatives in thinking about advanced care planning and goals of care discussions. There's the Conversation Project, as well as Prepare for Your Care, which both have COVID-19 specific content on them. And with that, I'll stop and thank you for your attention.
Thank you, Dr. Curtis. We'll take questions at the end of the sessions. I'm trying to share the screen for Dr. Howard. Okay, while we figure that out, Dr. Soundararajan, are you ready to go? Dr. Sugandhi Soundararajan, I see you. Can you unmute yourself, please? Thank you. It's my pleasure now to introduce Dr. Sugandhi Soundararajan. She is a professor of pathology at Zucker School of Medicine at Hofstra. And she's going to be talking about a very, very important topic of what pathology is in COVID-19, where they have seen a lot of pathology in New York area. Thank you.
Thank you very much. I just have to share my screen now. Hello? Can you see my screen?
No.
Okay.
Can we hear you?
Can you hear me?
Yes, we can hear you, but we cannot see your screen.
All right, let me try again.
But I think downsize it first, this screen, then open up your PowerPoint, then again come back to the screen and click share screen.
Yeah, I did that.
Okay, maybe email Vijaya. I'll put the email. Yes, I think, yeah, it's working. Great.
Okay. Now is it good?
Yes.
Okay.
Very good.
All right. Thank you very much for this opportunity. I thought I'll just share the experience from Northwell with all the autopsies that we did. And most of the information that I have is already published. So it will be a combination of what's in the literature and what we have in Northwell. The topics I'm going to cover are the lungs, the cardiovascular system, kidneys, brain, and a little bit about the lymph nodes and maternal fetal health. So just for a recap, there are like 3 stages in this infection with COVID-19. The first part is basically the inhaled virus, which binds to the epithelial cells in the nasal cavity. And that's where the infection starts. And at this stage, the PCR test can be positive. The second stage, the virus goes down the respiratory tract along the conducting airway system, and here a more robust immune system is triggered. At this time, patients may not be symptomatic or they may be symptomatic, and 80% of the patients who are infected are in this stage. And again, nasal swab and sputum can be positive for the PCR testing. The third one, and this is where our pathology contribution is present, the virus reaches the gas exchange units of the lungs and infects the alveolar type 2 cells, also called the pneumocyte type 2 cells. Here, the earliest part of the pneumocyte is in the subpleural space and also in the peripheral lung. And the SARS-CoV propagates into the type 2 cells, and a large number of the virus particles are released. And eventually what happens is the pneumocytes undergo apoptosis and die. During this time, it creates damage, and the end result is basically remodeling of the lung. And many of our pathology does not cover that topic because we do not have the late stage and we do not have surgical pathology or lung biopsies to prove what the late stage looks like. So what I am going to present is basically the earlier stages of stage 3 and the late stage of stage 3. Fortunately, only 20% of the infected patient progress to stage 3. Just to recap how normal lung looks like, it has smooth surface and the weight is usually around 500 grams and it is crepitant. So when we touch it, it rebounds back. The reason I'm telling that is in COVID, things are changed. So the upper respiratory tract, what happens is it's essentially normal. There's just a layer of mucus. Otherwise, the upper respiratory tract up to the bronchus, everything looks normal. Again, this is another example of an autopsy lung, which is just showing you that there is only mucus-lined tract. On cut section, which is on the right side, the lung, which should be crepitant, it's almost like consolidated and it almost looks like liver. And the pleural surface has some petechial hemorrhages. Normally, it should be the color which is seen on the upper portion of this lung specimen. And we have some areas of congestion. This is another cut section of the lung. And if you now see the weight of the lung, each one is around 1,000. And as I said earlier, it should be around 500. And if you let it float in water, it will literally float. But these lungs will sink in water. And when we touch it, there will not, the crepitancy is gone. And the other thing which we also saw was when we expressed, a lot of fluid came out of the surfaces of the lung. So they are heavy lungs and there is firmness in the whole lung. Again, to recap the histology, these are the alveolar linings and all the empty spaces are the air spaces. There is literally nothing which should be present within these empty spaces. And here is an example of the bronchial wall, which is clean. And this is another example just to show you the bronchial system, the blood vessels, and the very thin alveolar septae. And this is much more higher power of the alveolar septae, which is basically a very thin lining of capillary. And this is the filter through which air is diffused. And if you see, there are single cells, and those single cells which are present are the type 2 pneumocytes. And all this empty space is the air. So this is what happens in the patient with COVID. The whole field is red, and that is because all the bigger blood vessels are congested and all the alveolar septae, which are made up of capillaries, are also congested. So this is again an earlier phase of stage 3. So, and within the air spaces, there are some desquamated cells. So at this stage, we can say there is congestion and there is slight thickening of the alveolar space. And what I want you to note is we do not have infiltration with inflammatory cells. There is no pneumonia. If it was pneumonia, all these air spaces will be filled with neutrophils if it's acute pneumonia, and there'll be a mixture of both neutrophils and macrophages if it is chronic pneumonia. So there is no inflammatory infiltrate within the parenchyma. This is also another patient with COVID. And what we are now seeing is all the air spaces. Again, this is air space. And again, this patient has emphysema. That's why we have larger air spaces. But other air spaces are filled with pink substance. That pink substance is pulmonary edema. So now we can understand why they were expressing fluid when we were pressing the lung, and also why they were heavy. So there is pulmonary edema and pulmonary congestion. Moving on to a later stage, this is where we call diffuse alveolar damage. And the normal architecture of the lung is altered, and that is because there are many things which are happening. The lower picture shows the alveolar capillaries being more dilated, and these bigger cells are the pneumocytes, the type 2 pneumocytes. They are more prominent, and that's called pneumocyte hyperplasia. In this field, in this lower left lung picture, there is no alveolar inflammation. If you see the other side, there is a pink substance lining the alveolar space. So this is the fibrin, and this is what we call hyaline membrane. And we also see the hyaline or the fibrinous area, which is lining the alveolar septae. One more stage, or a later stage in the diffuse alveolar damage, this hyaline gets more organized, and there is remodeling within the alveolar septae. Just to compare, the normal, which should be a very thin layer of capillaries, now has become this thick. The outermost, or what is facing the air, is hyaline membrane, and in between there is a proliferation of fibroblasts, and there is pneumocyte hyperplasia. And now you can imagine why there is no air going into the vascular system. This is like comparing a filter mechanism which is clogged by, say, soot, or some, like if you talk about filter mechanism clogged up with dust, that's what happens to this filtering system, which is the alveolar system. Another picture of the same diffuse alveolar damage. So this is the major lung pathology in COVID patients. And of note, there is no infiltration of inflammatory cells to call it a pneumonia. Moving on to the electron microscopic picture. This is an example of the first coronavirus. So all these small rounded particles are the coronaviruses, which are present in the type 2 pneumocytes, and they get exuded out into the alveolar space. And here is one of those articles which shows a type 2 pneumocyte on the left, which is a slightly lower power, and all these rounded structures are the virus particles. And this is another higher magnification of the virus to show you those spikes. And the coronavirus is around 90 to 110 nanometers, and this is similar to that. And this is an example of the EM picture of this virus. And they are present within the type 2 pneumocyte. So I'm now going to move on to the coagulopathy which happens in these patients, and I'm going to start in the lung. So this is another this is a picture of the diffuse alveolar membrane here and the alveolar septae. And what I'm going to show you what happens within these capillaries in the next image. So if you see within the capillaries, there is pink material or fibrin. So the capillaries within the alveolar spaces are filled with small microthrombi. And these microthrombi are filling up the alveolar capillary wall. This is part of the coagulopathy. And if you look at slightly bigger vessels, again, these are still the microvasculature of the lung. We can see the alveolar septae, and they are clogged up by small thrombi. And we don't see any vasculitis. The wall of the vessel is still clean, but small microthrombi are present. And this was one of our patients where we have the congestion and there is a slightly bigger vessel. But this was one of those patients who had inflammation within the vascular wall. So we can call it vasculitis. And this is a higher power of the same vessel. So we have endothelium, which looks a little bit activated or swollen. And within the wall, we have lymphocytes within the wall. So that is the vasculitis part. Another vessel where we have the thrombi. So this is the vessel wall. And the pink material is the fibrin, and the red part is the red blood cells. What we also saw in 2 patients, this is again during autopsy to orient you. This is the lung, and here we have the lung, and there is that other lung. And we open the pulmonary artery before we do anything, before us dislodging. So what we see here is a big thrombus, and that is a saddle thrombus. So this is a massive pulmonary embolism. And this was a published patient case where they also have a very big thrombus filling up the pulmonary vessel. And the cut section and microscopic image looks like this. So this is the wall of the pulmonary artery. There is no vasculitis, and again there is lung tissue here. And within the lumen, we have the thrombus which is sitting inside the lumen, and this is another picture of the same thrombus. So all these are bigger vessels with thrombi. What we also saw are peripheral vessels with thrombus activity within the vessels. So they also look like this, and I don't have an image of the peripheral system with thrombus. And again, another picture of the artery with the thrombus. And again, I want to show you that there is no vasculitis in these bigger vessels. So that is about the lung and the microvasculature and the vasculature of the lung. Now moving on to the lung, this patient, again, this is a cross section of the heart. We have the left ventricle and the right ventricle, and this patient had hypertension. So because of the previous history of hypertension, there is left ventricular hypertrophy, and also there are some white areas which are probably evidence that there was previous myocardial infarction. Other than that, we did not see any major hemorrhages within the heart or new macroscopic injury. However, on microscopic examination, and again, this was a published case, the myocytes had some vacuolar changes, and that is evidence that there is myocyte injury. Again, to point out, there was no myocarditis, there is no viral cytopathic effect, and there is no myocarditis. And this is an image of the heart, and this is the pericardium. And in this patient, there was inflammation of the pericardium to suggest that there was some chronic pericarditis. Whether it is due to this virus or whether it was previously present, we don't know, but this was a patient with pericarditis and myocardial injury. Moving on to the brain, again, this is a recent publication where just corresponding to New England Journal, there were autopsies which were done, and they are showing what the macroscopic image was in the brain. Most of them had atherosclerosis, and if you see the histologic analysis, almost all the 18 patients had acute hypoxic ischemic damage of the brain, and very few patients had some lymphocytic inflammation like encephalitis. And the image, again, just to orient you how we examine the brain, and this is not a COVID patient, we cut through the brain and line it up and examine what is macroscopically present. And in this brain, there is hardly anything. And as I said, this is not a COVID patient. And this is an example of how a COVID patient's brain looked like. The weight was increased. That suggested edema, cerebral edema. And all these dark spots are microhemorrhages. And we can see them even in this. So this brain had microscopic or hemorrhagic lesions, and they measured from 1 millimeter to 1 centimeter. And this is the microscopic image of the brain with some hemorrhage and some, again, there is no inflammation. And when they stained with macrophages, these brown cells are macrophages, which should not be there. So when we have macrophages in an area of injury, that tells us that there is acute hypoxic injury or acute neuronal injury. So that was what was seen around the areas of hemorrhage. And this is another image of the brain, and there is a microinfarct, and that microinfarct has some surrounding changes, glial changes, and they also had macrophages. So all this points out that probably there is endothelial damage, and because of endothelial damage, there is thrombi formation, and because of that, there is microinfarcts. So those were the findings within the brain. And there was another article published where they found corona-like viruses within the endothelial cell of the brain. And none of the publications revealed like viral cytopathic changes within the brain. And a few reports were there where there was like lymphocytic inflammation to suggest encephalitis. Moving on to the kidneys. This is again just to show the kidneys had evidence of older disease because we cannot see the cortex and the medulla clearly. Otherwise, there was no hemorrhage, there was no infarct, there was no abscess formation. And microscopically, what we saw was this, like if you see the tubules, the tubular epithelial cells are still intact. But if you see on the right side, the same tubular epithelial cells are somewhat vacuolated, or the cytoplasm is edematous. So that is an indication that there is acute tubular injury. And another image of another kidney to show that there is acute tubular injury and there is sloughing of the tubular cells. So that is acute tubular necrosis. And within the glomeruli, again, this is an example of glomerulus, which is shrunken. And all this is Bowman space. So when we see shrunken glomeruli, that gives us an indication that there are some acute ischemic changes. And in this glomerulus, there are some fibrin thrombi. And otherwise, the glomerulus looks good and there is no inflammation within the kidney. So to summarize the kidney findings, there's acute tubular injury and some cases showed microthrombi within the glomeruli, and there were no immune complexes found within these glomeruli. About Kawasaki's disease, this is like an acute multisystem immune mediated vasculitis. So because of the multisystem disease, there can be multiple areas where the mucosa becomes red, and even the microvasculature of the skin can have vasculitis, and they can have some petechial hemorrhages and some reddish hue with almost like gangrenous look. So did we get any specimens from these patients? I don't think we got. Even lymph nodes we did not get. Most of this was clinical diagnosis. If we were to have a lymph node biopsy or a lymph node excision, this is how Kawasaki's disease will look like. Again, there is microvasculitis. So the vessels of the lymph node will have inflammation to qualify this as vasculitis. And because there is endothelial injury, there can be some microthrombi, just similar to how we saw in the lung. And because of that, the lymph node can have small, like microabscesses. Just to refresh, normal lymph nodes, which is on the right, should have nice germinal centers, and all the cells within the lymph nodes should only be various types of lymphocytes. But if you see a Kawasaki's disease lymph node, there will be some small neutrophils, collections of neutrophils, not huge abscess formation, but just small collections of neutrophils, which is like necrotizing lymphadenitis, and the lymph nodes will be enlarged. No granulomas were found. Should be present in Kawasaki's. This is another publication just to see if any impact is present in maternal population. And about 38 pregnant women with COVID patients were studied. None of the newborns had the disease, and the placenta also did not show major findings like vasculitis or bilitis. So in terms of pregnancy, there is no evidence of vertical transmission of COVID-19 from the mother to the fetus, and all the pregnant women delivered a live newborn. This is just to thank our autopsy director who shared the data with me. This is what we did. Normally, we get autopsies at the request of patients, but during this time, these patients were selected by the clinicians, and very few autopsies were performed just to have a spectrum in terms of age. Most of them had diabetes and hypertension or some other morbidities like breast cancer, obesity, and atherosclerosis, and one of them had asthma. And what we found, most of them had acute lung injury in terms of edema and hemorrhage. 2 of them had pulmonary thrombi, and microthrombi were present in 2 patients. And in terms of upper respiratory tract, there was not much inflammation, and almost all of them had acute tubular injury. Just some pertinent negative findings at autopsy. We did not find microthrombi in the vasculature of the kidney, except those small microthrombi in the glomeruli. There was no significant inflammation in the airways or within the lung parenchyma. There was no evidence of myocarditis, and there were no macroscopic hemorrhages in any of the organs. And we did not see any organ with viral cytopathic effect. I just want to give an example of what we look for whenever there is an infected tissue. This is an example of CMV infection, and this is an example of herpes infection. There's usually an intranuclear inclusion, and in this herpes, there are multinucleation and intranuclear inclusion. These type of viral cytopathic effect were not identified in any of the autopsies. So that is the end of my presentation, and if there are any questions, I'm ready to answer.
Thank you so much, Sugandhi. I think it was an excellent presentation on pathology and also the autopsy findings. Usually as clinicians, we are more on the other side, taking care of patients, but I think pathology is the backbone of clinical diagnosis and treatment. So thank you very much for sharing all those slides. Our next speaker is going to be is Dr. Nicholas Hill. He's a professor in chief, pulmonary critical care medicine, Tufts University School of Medicine, Boston. He's a past president of American Thoracic Society, but more than that, he's been my mentor in Massachusetts, and he's a world-renowned leader and has so many publications to his credit on non-invasive ventilation and pulmonary hypertension. And he has written so many articles, awards, and he's mentored so many fellows. And we always look forward to his talks during the board exam review courses and in all places, wherever we are learning pulmonary critical care medicine. And he's a very good friend of the pulmonary conferences which happen in India. I've seen him fly to India even during Thanksgiving time to attend the pulm conferences and to share his experiences. So we feel really humbled to have you, Dr. Hill, today with us. It's all yours. Thank you.
Thank you, Saras. Are you able to see my screen?
We are.
Oh, good. There, is that better?
Yes.
Okay. Well, I have been asked to talk about one of my favorite topics, non-invasive ventilatory techniques. and how they can be applied in the COVID-19 pandemic. These are my disclosures. And I divide these techniques now in a few different ways. We, of course, have high flow nasal cannula, which is what's being illustrated here. And you can see the soft, relatively comfortable interface there. And this, of course, is a set flow rate. And although some people during the COVID pandemic have been using flow rates as low as 10 or 15 liters per minute, I think unless you're using at least 30 and perhaps higher, you really are not using high flow, and I'll point that out in a little more detail in a moment. The gas is heated and humidified, and this is very important for its tolerability, because if you had a dry gas being insufflated into your nose at those rates, you would rapidly desiccate and become uncomfortable. But with the heat and humidification to body conditions, it enhances tolerance and also helps with mobilization, hydration of secretions, and preservation of mucociliary function. Non-invasive ventilation, on the other hand, is a pressure target as opposed to flow with high flow nasal cannula. The heating and humidification is variable, and it's not necessary to use heat and humidification, but most people do. And tolerance is considerably less than with high flow, but varies considerably between individuals, and from time to time, most people have to take breaks. And then to this list, I have recently added awake proning, which is something that has gained a lot of traction with the COVID epidemic and can be used either with just standard O2 alone or in combination with high flow or non-invasive ventilation. These techniques have been highly controversial during the COVID pandemic. On one hand, the use has been strongly discouraged at a lot of institutions, some in New York. I think some of the Northwell institutions were very reluctant to use them, and New York Presbyterian as well. And the major reason was that they are considered aerosol generating procedures. This, of course, is how the disease is spread, and they were considered dangerous for staff. And at those institutions, the strategy was to intubate early, get the patient intubated, get the aerosol in a closed system, and minimize exposure to staff.
Right.
Now, on the other side, people would argue that you should try non-invasive ventilatory techniques in appropriately selected patients, that there are some patients who might be able to get through their episode of respiratory failure without having to be intubated. That may lead to better outcomes in some patients. And also you can preserve critical care ventilators for those who really need them. And some of the earlier reports on outcomes with invasive mechanical ventilation, especially from China, some places in New York and Washington state, have been pretty bleak. And there's been a lot of concern that maybe we've been overly aggressive with intubations. This controversy is reflected in the guidelines that are available. I've just listed a few for example here, but in late April, the Surviving Sepsis campaign, sponsored by the Society of Critical Care Medicine, came out with a guideline that suggested high flow as your first choice if you're going to use a non-invasive technique. And they actually didn't classify it as an aerosol generated procedure. They suggested use of NIV, but with the asterisk means that only if high flow is unavailable, and for some of the better indications for non-invasive, such as COPD exacerbations or acute pulmonary edema, if they're seen in COVID patients. The WHO, on the other hand, said that these things should be used only in very selected patients, not routinely. The Australia-New Zealand guideline recommended first use of high flow and discouraged the use of NIV. And this is because the evidence we have suggests that NIV is more of an aerosol dispersant than high flow. And then in Boston, the Mass General Brigham group discouraged the use of high flow, and at Tufts, high flow we consider an option, but in both cases, we weren't too thrilled or enthusiastic about using NIV. Now, I want to make a few statements about high flow and some of its physiologic benefits. I've already mentioned the secretion hydration, but it is an effective oxygenator, and it does so via primarily two mechanisms, one being that with the high inspiratory flow rate, it keeps up with the high flow rate of dyspneic patients, which can sometimes exceed 60 liters a minute, but it's a lot closer than you get with a standard nasal mask, which if you use an NRB, that goes up to 15 liters a minute. So there's a lot of room air entrainment and dilation of FiO2, which is reduced with high flow, at least at adequate flow rates. Also, during expiration, you're flushing out the nasopharyx and you're reducing dead space so that the first bolus of air you inspire is not the air you've just exhaled, but is partially freshened by the high flow gas. Because of the washout of dead space, there's improved ventilatory efficiency. And if you're washing out, say, 50 cc's with each breath and you're breathing at a rate of 30 per minute, 30 times 50 means that that's about 1.5 liters per minute that you don't have to breathe to achieve the same alveolar ventilation. It also pretty consistently reduces respiratory rate, which leads to a decrease in the work of breathing per minute. And there is a positive expiratory pressure effect, and end expiratory volume has been shown to be increased in some studies, which may be another mechanism for improving oxygenation, at least somewhat. This is working here. So what I'm showing you is the flushing out effect at 15 liters, 30 liters, and 45 liters a minute. And so if you here's 15, 45, we'll stop it right around 2 seconds. And you can see that the flush out is considerably greater at 45 than 15. And 60 is actually the highest you can go, which would be even more flushing. But the point is there is a dose-response relationship, and you get considerably less flushing of dead space at 15 liters a minute than you do at 45, and even less than at 60. So it is important to use higher flows. I always say, if you want to use high flow, use high flow. Non-invasive ventilation, the main indications are hypercapnic respiratory failure due to COPD that we've known for a long time, and there are physiologic mechanisms, including counterbalancing of auto PEEP with extrinsic PEEP, and decreasing work of breathing using pressure support during inhalation. Also cardiogenic pulmonary edema, largely due to the increase in FRC, whether you use CPAP or BiPAP, and the opening of flooded alveoli, which improves oxygenation and reduces lung compliance. The role in hypoxemic respiratory failure and ARDS has been unclear for a long time. There have been studies showing significant benefit and others not. The failure rates have been considerably higher in this group than with the COPD or acute cardiogenic pulmonary group. And the recent ERS ATS guideline that was published in ERJ 2017 that I sat on came out with a no recommendation, meaning the data was insufficient to support either a statement for or against. This doesn't mean they didn't recommend it. Some people have misinterpreted it that way. They did allow for its use under special circumstances in the right situation, but they felt that the data was not strong enough to make any recommendation. And I show this to illustrate the differences in the pressure contour you get with high flow and NIV. In the green below, we're looking at the nasopharyngeal pressure of someone getting high flow at 60 liters a minute. And during expiration, early on, you get the peak, and the pressure is, if the mouth is closed, is equal to about 1 centimeter of water for each 10 liters per minute of flow. As exhalation proceeds, the pressure dissipates as the expiratory flow falls off. And then during inspiration, you get a dip in pressure. Here it goes down to about 2, but if the patient was pulling hard enough, they could go below 0. And then during expiration, you go back up to around 6. In blue, the bilevel settings are 12/6. So during expiration, early on, there's virtual superimposition with high flow, but during inspiration, as it should, it goes to the targeted 12. And there's a big difference between the pressure delivery during inspiration with NIV than high flow that is probably important in situations where pressure is important, such as COPD exacerbations, where you want the pressure support with inhalation, and also cardiogenic pulmonary edema. And those are situations where I think NIV still should be considered the mode of first choice over high flow. The main indications for these non-invasive ventilatory techniques relevant to the COVID pneumonia are, one, these patients, of course, with their pneumonia come in with hypoxemia. The hypoxemia may progress, and you can use them to oxygenate when nasal cannula or O2 masks are not sufficient. The cutoff I use is 6 liters or more with nasal cannula, or FiO2 40% or greater with a venti mask, inability to maintain O2 sats 92 or above. We also use them commonly to facilitate extubation. There is data on this in the pre-COVID era. We don't have data post-COVID, but we find that these patients who have prolonged courses with invasive mechanical ventilation are very deconditioned. They often have secretion issues, and the hydration you get with high flow can be helpful, and it does maintain their oxygenation better than standard oxygen. And we have combined high flow and NIV in some of these patients in a complementary fashion, and find that the NIV helps to rest their muscles a little bit better, and the high flow helps to hydrate their secretions and give them a break from NIV. And that combination, we think, has worked pretty well. There is a pre-COVID study from JAMA, an RCT out of France, that showed that the combination was better than high flow alone in that setting as well. And we use it with or without proning. Now, proning may be used with standard oxygen before your oxygenation gets too severe. We usually start it when the PF ratio is less than 200. Some people even higher, and it's awake proning. We can also combine it with high flow or NIV, and the high flow in particular facilitates the use of proning. People tend to tolerate proning better with high flow than, say, a mask or a helmet, and they do tolerate it pretty well with standard oxygen, although usually we have them on high flow because their oxygenation has deteriorated sufficiently. Now, the issue of aerosol dispersion has been the source of a lot of the controversy, and what I'm showing you here is a summary slide of some of the studies that have been done to look at dispersion of aerosol, and most of them have come out of Hong Kong. David Hui, H-U-I, who has used a mannequin surrogate of a human ventilating. He uses a ventilator and a semblance of an upper airway, and he uses smoke as his surrogate for aerosol, and he has a laser light to pick up the dispersion. And he's found that non-invasive ventilation disperses aerosol about 1 meter. With simple masks, a bit less. Actually, intubation is even worse than non-invasive. And now here's high flow getting out just beyond 10 centimeters. And this is at 60 liters a minute. The difference between low flow at about 10 centimeters and 60 liters per minute was going from 7 to about 17 centimeters. So an extra 10 centimeters, which probably especially in the context of these other dispersants, is not significant. So the idea that you need to use lower flows with high flow to prevent more dispersion is overblown. And this is a recent study out of chest showing the effect of a surgical mask on the dispersion. Here in this upper right figure, we have somebody using high velocity nasal insufflation, a slightly different manufacturer of a high flow system. And there's no surgical mask. And you can see at 40 liters a minute, there's this amount of dispersion. You put a mask on it and it's virtually eliminated. The mask has to be properly fit, of course. From a practical point of view, I've emphasized the importance to start at relatively high flows. I usually choose 50 liters a minute because most people tolerate it. Some people don't tolerate 60, but you can titrate up to it. If people are intolerant, you can titrate down a little bit. The nasal prong should be firmly but not tightly placed, and that seems to reduce any dispersion. And just once you get them on a flow, you adjust the FiO2 to your target. We usually target greater than or equal to 92%. And temperature, you have to sometimes dial down a little bit. We start out at 37, but a fair number of people find that a little too hot. With non-invasive, I start relatively low initially and then up titrate. We've been using mainly face masks, and we use it secondary after high flow. High flow is what we go with mainly, but in Italy, the helmet was their main interface. At some of the centers, 70–75% of their applications use the helmet. And if you use the helmet, you have to use higher pressures because of the compliance of the plastic hood, and you need to distend that adequately. With proning, awake proning is different than during invasive mechanical ventilation. People cannot tolerate for long periods of time. So most people go for maybe a couple hour sessions as tolerated several times a day, trying to shoot for up to 6 hours per 24. One of the big deals with non-invasive ventilatory techniques is the monitoring for failure, either with high flow or non-invasive, because especially with COVID, if things get out of hand and you have an emergency intubation, it's a disaster because your intubation team takes several minutes to get the PPE on, that the patient is placed at greater risk because it takes some time to get into the room. So we try to anticipate, and so we watch the vital signs very closely. We look at respiratory rate and accessory muscle use in particular. A high work of breathing would indicate intubation. They get hypotensive or hypoxemic. Obviously, those are problems, altered mental status, multi-organ system failure, more prolongation. A lot of these patients who end up on invasive mechanical ventilation are on ventilators sometimes for weeks, and that's not for non-invasive. There is something that was described first a couple of years ago, and then a validation study was published in the Blue Journal about a year and a half ago, and it's called the ROX score, and it is the SpO2 FiO2 ratio divided by respiratory rate. So it gives you an index of gas exchange and respiratory rate as kind of a surrogate of breathing effort, and the higher the number, the better. In other words, the higher your SF ratio and the lower your respiratory rate, the better you are, and vice versa. So they have come up with some indices of how to apply this, and it can be helpful in anticipating failure. But the bottom line is avoid delayed intubation that leads to these emergency disasters. So to summarize, non-invasive ventilator techniques have advantages for COVID patients and may avoid intubation for selective use. But in the end, most patients who are developing pneumonia, ARDS, probably are going to get intubated, but the point is you're trying to get a significant minority of these patients and avoid intubation. It must be applied selectively and monitored closely in an ICU or an intermediate care unit, and you watch closely for impending failure. It's critically important to use meticulous PPE technique, but in our COVID units, we have had very few healthcare workers turning positive that can be attributable to their exposures at work. it appears that most of the people have turned positive in our hospital because they've been spread all over the hospital. The people have turned positive in areas where they're not getting much clinical exposure. And so the thought is that probably most of these positives are related to community exposure. Anyway, I will stop there. Thank you for your attention. And I think we got to move on to our next speaker.
Thank you. Thank you so much, Dr. Hill. That was very, very informative. Dr. Guntupalli?
Yeah, Dr.
Questions for you,
Howard,
Dr. Hill.
Yeah.
We'll come back.
All right, everyone. Hi, this is Chris Howard. I'm going to try to do a share screen. If not, looks like this may work this time.
Great, it's working.
How's that look for everyone?
Very good.
Well, we have not had a chance to meet, but this is I loved your lecture. I really enjoyed those figures of the high flow. Those are fascinating. And fortunately, my topic will kind of be a nice segue into the next discussion. We're down here in Houston. We had a relatively modest burden of cases early on, and kind of March, April, things really settled down in May. Everybody was feeling pretty good in the area, and things opened up in Texas and Houston in May, and we're really paying the price now in June. We're seeing tripling and quadrupling of cases. We're about to open up our 4th and 5th COVID units. So we were right in the middle of this, and I don't know how much your experience was like ours. At the beginning, when we're watching Italy and China, Seattle and New York, their experiences, there was no published data. Everything was anecdotal. Everyone was on the email chains. Everyone was on these group phone calls trying to understand how much this is actually different from the previous pneumonias, previous ARDS, and what do we need to do? What do we need to do differently at an individual level to try to treat these patients? Because it just seemed like such a novel pathophysiology. Let me start by kind of giving you a quick overview of where we start in our hospital in terms of refractory hypoxemia. We put this together roughly the same time a couple of years ago as the ATS, CHEST, and all the professional societies were essentially putting their guidelines out. And it pretty much mimics that. I think obviously the first step once a patient is intubated, we're looking for low tidal volumes, low driving pressures, optimize your PEEP. And then we kind of move on to other things in a various different order, whether it's in terms of inhaled epoprostenol, paralytics, and proning. And then obviously if those are all, if your hypoxemia or hypercapnia is refractory to those measures, we're moving on to ECMO. So nothing terribly revelational here. This is, I think, for the most part, pretty similar to most institutions, but I just want a starting point for the conversation and to figure out what has changed and what has not. Again, I don't know if you were like us. We were listening to stories in terms of getting on mechanical ventilation. I feel like the pendulum was swinging all over the place. Early on, it was, you're intubating way too early or you're intubating way too late. And, between the day and the group that you were talking to, I feel like the guidance was changing significantly. And everybody's just trying to figure out, where's the truth in all this? Where's real, how are we going to find out the best time to do all these interventions? This is kind of our modified COVID protocol. Basically, very similar to what Dr. Hill mentioned. Once we're beyond about 5 or 6 liters nasal cannula on the floor, we're escalating to the ICU pretty quickly. Transport options are things like non-rebreathers with a patient mask. We'll talk about some other interventions we come up with to minimize healthcare worker exposure. The one new thing, and I guess the nuance, and it's interesting here, Dr. Hill's experience, we have been pretty aggressive with our high flow nasal cannula as a non-invasive option. We've opted not to do positive pressure ventilation with a traditional face mask because of aerosolization risk. And we've had a reasonably good experience with our high flow nasal cannula. What happened very quickly to us is we're realizing they're certainly just our patients who you just know when you look at them that they're going to benefit from some sort of non-invasive positive pressure ventilation. And this is the reason we were very aggressive up front, trying to get some helmets in our institution. And we've applied it roughly 15 to 20 patients at this point in time. The main 2 groups of patients we were noticing that really benefited were those who were obese with compromised FRC, and then those with concomitant and concurrent pulmonary edema, perhaps from left-sided heart failure, in addition to their COVID infection. The part I really wanted to focus more on is kind of how we get to mechanical ventilation. As I mentioned, in terms of the decision to actually do that, I feel like the pendulum swung from one place to another. JAMA was telling us early on we definitely needed to intubate early and perhaps even to the point where if you're failing low flow nasal cannula, 4, 5, 6 liters, don't even worry about non-invasive methods, just go right to the mechanical ventilator. And then I feel like subsequent weeks, the pendulum was kind of swinging the other way. It's certainly understandable to want to intubate early. One, you want to make sure your patient is stable. You want to avoid the emergency intubations, the high aerosolization. And then Dr. Gaetnoni has described this, as many others. There's kind of a patient-induced self-lung injury when you have those huge transpulmonary pressure swings with all the negative pressure ventilation that the patient generates. You can actually induce a lung injury there. So you want to stop that cycle early on. But then we kept hearing kind of later, I feel like mid to late in the New York outbreak, I feel like we were getting a lot of anecdotal feedback from the New York hospitals, specifically that perhaps we're intubating too early. We think a lot of patients can do okay with some non-invasive methods and really trying to put off those intubations. Because as we all know, the ventilator is not necessarily a benign intervention, whether it's life-saving, surely, but definitely it's not always a benign intervention. We have to do things to make sure that we're not causing further injury. Not to mention all the sedation that's required. I feel like that's been the second biggest challenge of patients on a ventilator, whether it's the delirium or whether it's the minute ventilation drive that the patient generates. I feel like the sedation needs of these patients, by and large, are significantly higher than a standard acute respiratory failure for pneumonia. So the pendulum has definitely swung. Even in the lay press, this really didn't penetrate much into clinical circles, I don't think, but even some nurses were saying, I think this came out of when the New York hospitals were quoting 80% mortality for anybody who's on a ventilator. So people extrapolated that incorrectly and said, well, the ventilator is actually causing death. So don't let yourself get on a ventilator. Don't you let your family get on a ventilator. So I feel like this penetrated for a few weeks in the lay press and it's kind of died down. But just another example of how the pendulum swings and from one extreme to another in such a short amount of time. And that's kind of, in terms of once the patient's on the ventilator, everybody's asking, does this actually just represent viral pneumonia, as we've seen in the past? There's actually kind of novel pathophysiologies, and are we going to need to adopt new strategies? So the question came up, is this ARDS like every other ARDS? And I think probably like many of you, I read those 50-page long email chains from Italy that were coming out from very early on. People like Dr. Gaetnoni were saying, we think this is maybe something new. And he certainly made a compelling case for that. He was kind of describing a cohort of patients who had very severe hypoxemia, but perhaps their respiratory drive was actually not that high. And in some of his letters to JAMA and to the Blue Journal, he basically attributed this to poor lung perfusion regulation and hypoxic vasoconstriction. So that he was saying that perhaps the common ARDS recommendations for higher PEEPs and even proning maybe are best avoided in these patients because either it's ineffective or maybe even injurious, especially with some of your higher PEEPs causing cardiovascular compromise. So he kind of described these as, the two new phenotypes, the L and the H, kind of correlating with the elastance, which obviously is the inverse of compliance. The L group is kind of the novel group. The H is kind of the traditional group where we got a lot of pulmonary edema, a lot of lung injury, a lot of heavy weighting, so to speak, on radiographs. And these are the patients that will respond to proning and higher PEEPs and perhaps even recruitment. The L is kind of this novel group. So this, I think this penetrated, I don't know what your experience was with your hospital. I mean, we had doctors, every doctor in the hospital was talking about L and H for weeks, trying to figure out how to best manage these patients on the ventilator. And then in subsequent weeks, I feel like additional recommendations and reports were coming out. This is a nice JAMA figure here that Dr. Marini and Dr. Gaetnoni put together, and I'll
Hello. Hi, Dr. Howard. Looks like we lost you. Hello. Hi, Dr. Howard.
Can anyone hear me now?
Yeah, now we can hear you. Yes.
Thank you. Dr. Guntupalli, we can't hear him again. We lost him.
Dr. Howard, we can't hear you again.
I think his screen also
Can you
froze.
hear me now?
Yes.
Again now,
Yes, please.
but then you went out again.
I think you're going in and out.
Can I do audio through here?
Hello?
All right, here.
Okay, he's back.
Can you hear me now?
Yes, please.
Oh,
If
boy.
it stays.
Sorry about that. Our neighborhood internet is out. I'm actually using a phone hotspot, so I apologize for that.
Well, that's resourceful.
It's okay.
So let me continue. So the top of the red box there talks about the novel L type, which is a little bit, again, we're kind of getting out of our comfort zone, right? We're used to moderate to high peeps for ARDS, and they're recommending we use lower peeps and actually even higher tidal volumes that we would normally feel comfortable with, 7 to 9 ml per kilo. This makes people a little uncomfortable, so we're not quite sure. And then the type H in the lower part there is mentioning kind of what we're used to, the moderate to high peeps, lower tidal volumes. They actually use the cutoff of 50 ml per centimeter water in terms of their compliance cutoff there. So they're basically dividing everybody into 2 groups. So what I'd like to show you very quickly is 2 subsequent studies that have indicated that perhaps this isn't the best way to go, or at least would be in contradiction to this. A gentleman named Dr. Zier from Mass General put this study out, and they looked at a larger scope. Dr. Gatnonius was on a small sample of cohorts, about 16 patients. This study here is for 66 patients. And as you can see here, the compliance, depending on the day, is really all over the place. There's no way to pick a particular, you'd have to pick an arbitrary cutoff to understand or to basically designate everybody into a single one of 2 groups. They basically said that their experience with their patients and their compliance measurements actually did not correlate with a dichotomous designation, but this was simply very similar to previous ARDS that we've known for the past 30 years and is more of a spectrum. They used standard ARDS strategies with everyone, and they felt that they had favorable outcomes. So a slight bit of difference in opinion on this one. This is actually a more favorite study of mine. This is out of Amsterdam, and this is in Annals that I don't think it's in print just quite yet. They actually correlated not just compliance measurements, but also imaging, because I think a lot of this Gatnoni's description was based on imaging and the visual weight of edema, the visual weight of the opacities, basically how severe your image was, and that this perhaps also correlated with which phenotype you were going to be. Just to orient you very quickly, the H phenotype fit very nicely. You have low compliance and significant infiltrates on your imaging. And then on the bottom right of this graph, you've got your blue arrows, which kind of correlates with the higher compliance and not as much burden on your imaging, CAT scan, or your chest x-rays. Unfortunately, they had a majority of their patients actually did not fit nicely into one of these 2 categories. So again, they've kind of followed up. This is a group of 38 patients. This is another follow-up that kind of follows with what Dr. Zier at Mass General was seeing in terms of not everybody fitting very nice and neatly into one of these 2 categories. So perhaps an argument against putting everyone into an L and an H category. And so again, one of these pendulum swings, in terms of when to intubate, when is the right time, how do we even apply basic mechanical ventilation principles? And at some point, you're kind of just left with you and your patient trying to say, okay, this is the patient I've got. These are the set of circumstances. I have to do what I think I know. And this is basically just try to minimize the lung injury that the ventilator is creating. And you have to treat the patient that's in front of you. That's a kind of a common saying among myself and my colleagues, despite what all these non-randomized trials tell you, still have to treat the patient that's in front of you, still adhere to those old principles that have shown to be proven well and effective in the past. So this is another commentary, again, from another physician from Mass General and British Medical Journal. Again, she kind of went back to saying, this is a spectrum of ARDS that we know has existed. We don't feel like the pathophysiology is new. We feel it's just perhaps one end of the spectrum that we're seeing. So continue to use low tidal volumes, low driving pressures, optimization of PEEP to really find the sweet spot in terms of the compliance for your given patient. In our particular experience here, we definitely have found the same thing. Our respiratory failure patients with COVID, they actually will change compliance during the 1 or 2 or 3 weeks that they're on a ventilator. It will change day to day. Sometimes it'll change week to week. We'll see patients with the severe hypoxemia and not much distress. And I'm thinking about 3 or 4 that I saw last week with severe distress, but the hypoxemia is actually quite easy to manage. And then you see all the patients everywhere in between. So I feel in terms of what resonates with us, myself and us and our colleagues, is more on the line of treat the patient that you see in front of you, adapt to what the patient is communicating to you with their style of disease, and stick to those principles at least that we know that's better until we see really well proven randomized trials that are actually going to change our management. Stick to what we think what works best. But I think that's a really interesting back and forth between those different facilities, those different institutions. And I certainly appreciate the physiologic approach and the very insightful approach that all those doctors have taken. Again, just to add on a few quick points about our adjuncts that we've seen change. These are things that we have done in the past for ARDS, and just kind of give a sense of what we've actually improved upon, what we've actually done a little bit less. I find that definitely Flowland seems to be everyone's best friend. That's a common practice pattern, that we've actually increased the frequency of how many patients are receiving inhaled epoprostenol. Recruitment maneuvers, I think, kind of fell out of favor after the ART trial. I'm a little sad to see that. I think the ART trial was a bit aggressive, and that there's ways of testing recruitability as opposed to just applying severe recruitment maneuvers to every patient, but that's probably another topic for another time. I'm also a fan of esophageal pressure management, but I think in terms of inserting those and spending a lot of time in the patient's nasopharynx, putting these tubes in, people are trying to shy away from that just from a healthcare worker exposure standpoint. Paralytics has been interesting, especially after the Rose trial, that kind of made people shy away from using paralytics. And I think that's also been our experience here, even with the severity of the hypoxemia sometimes, even when you see patients improve with as needed paralytics, such as that is recommended perhaps in the SCCM guidelines. We're actually finding that we're proning earlier, and we're actually not paralyzing everyone that we prone. Non-paralyzed proning is something that's very well described in the literature, but I don't think it's very widely practiced. I think most centers will probably paralyze before prone, but we're realizing that some of these patients are requiring prolonged ventilation courses, and we want to minimize every bit of sedation and paralytics that we can because of the debilitation factor that they face after they are able to heal and get finished with their ventilator course. They're just so debilitated. We're trying to save every myocyte, so to speak, so they can regain function. And then the last two are kind of the more interesting ones, I think. Corticosteroids. Obviously, there's a lot of excitement coming from reports out of the UK. We've definitely leaned forward on the steroids. We started with the solumedrol infusion, and we've changed over to Decadron at this point in time. And in terms of anticoagulation, we got started very early on this one, and I think this has definitely helped us. We use heparin infusions for all of our ICU patients. That's based on a TEG protocol. We have noticed that the TEG protocols, heparin infusions are actually much less than when you go by a standard PTT protocol for perhaps DVT or PE. So we're generally seeing rates between 600 and 900 units per hour. So we're not seeing a significant GI or hemorrhagic cerebral hemorrhages or any kind of significant bleeding events from our heparin infusion. And it's served us pretty well so far. In terms of just micro innovations that we've seen in our hospital, and this will be the end of my discussion here. As I mentioned before, we've definitely been aggressive about using the helmet NIV specifically for 3 groups I mentioned before, the acute pulmonary edema, those with obesity, and actually those patients who are been on the ventilator for a while and getting extubated, they're very debilitated. They have a hard time basically just ventilating on their own just from neuromuscular weakness. And so a little positive pressure definitely helps those patients kind of stay off the vent for the first 24, 48 hours. We've definitely adopted COVID-specific units, nothing too novel there. And then one thing that I'm actually interested in is looking at flow lane aerosolization for patients who are not intubated. We are developing a mechanism to basically use an IV pump to run flow lane through an aerosolize that's attached to one of our ventilators, and we can actually find a way to run those through some of our high flow nasal cannula. Again, this would be for those patients who seem to be very comfortable with their breathing. It's just the hypoxemia appears to be kind of mandating that instead of going on a vent, perhaps there's one more option for us to use for these patients to help keep them off a ventilator. Just very quickly, again, one of my favorite innovations, this picture here on the left, we've been able to basically detach the ventilator monitor and put it outside the room and then leave the ventilator inside the room. For those of you who manage ventilators on these patients, it is unbelievable the pathologies and the asynchrony and the troubleshooting that I've had to do on one patient is more than I would typically do in a week in a general MICU. And so to be able to do that without having to go in and out of the room every single time and expose everyone has been a real bonus for us. And then this picture on the right is what we've come up in terms of the patients who are now trached, but still in what we interpret at least as is still being infectious. It allows us to obviously have suction access, oxygen access, but then there's the filtration there for all the outflow. So we've developed this recently in our hospital just to help, again, for the trach patients who are off the ventilator, how can we help reduce healthcare worker exposure in that arena? And then for transport and intubation, we use these hoods for patients who may be on high flow, even non-rebreathers, as Dr. Hill mentioned, there's a little bit of risk of aerosolization there. So we just kind of taken some additional steps and kind of homemade devices there that help kind of reduce healthcare worker exposure. So those are some of the things that we've been working on to try to improve patient care and reduce healthcare worker exposure to the virus. And I will finish there. Thank you for your patience. It was an honor to speak to all of you tonight.
Thank you. Thank you so much, Dr. Howard. That was very insightful and informative. We do have some questions before we finish the session tonight. The first question is for Dr. Nicholas Hill. It's on helmet, hood, mask, and the risk of aerosolization.
Well, you know, the thing about helmets is that there are helmets and there are helmets. And the helmets that they use in Italy are, they get from a company called Intersurgical, the StarMed mask, and it has an inflatable collar. And if you use that one and inflate the collar, you get virtually no dispersion of aerosol. And this is part of the reason they use it so often, that they feel that it's minimized exposure to patients. In the US, we don't have access to those helmets. So we've been using, at least at my place, the C-Long, which is the same one that was used at the University of Chicago. And it has some issues. It clamps on to a ring around your neck, and that clamp comes loose, especially if you're using higher pressure. So it pops off every once in a while, which I'm sure is great for aerosol dispersion. And also the neck seal is not inflatable. It's a silicone ring that you kind of cut to trim to the patient's neck size. And that lifts off and leaks every once in a while. So I haven't seen studies on dispersion with that one, but I'm sure it's not as good as what the Italians are using. Dr. Howard, you mentioned that you're using them at your place down in Houston. Which one do you have?
So we went with the C-Long just because it was more readily available to us. It's just a few hours down the road in Waxahachie. That's a nice Texas town name for you. But we also use the Amaron, which is out of San Diego. So we actually have a combination of both, and it typically depends on which is more available at that point in time to us for us to get in the warehouse, so to speak.
Dr. Howard, can we see you? You can turn your video on.
I do apologize. That is the one thing that definitely does not work is my video. So I do apologize for that.
All right.
It has nothing to do with the fact that he's not wearing business casual.
I'll never tell. I'll never tell.
So there's another few questions. One question is regarding barotrauma in these patients with the use of high PEEP. Any idea, or you want to know, the viewer wants to know what's the percentage of the barotrauma in these patients because you were using high PEEP?
I'd be glad to at least be one respondent to that. You know, it's been very interesting, despite us going back to what we think we know about ARDS, which is moderate to high PEEP. I have noticed on average that doctors are using lower PEEPs on average. We're still up in the double digits, the 10 to 12 to 15, sometimes even 18. In obese patients, we feel definitely more comfortable about going up to PEEPs of 18 and 20. But, you know, especially with these patients who are really ill, prolonged ventilatory courses, the compliance is terrible, 10, 15, and even just with 4 or 5 ml per kilo tidal volumes, the peak pressures and the plateau pressures are getting so high in the 30s, 40s, and sometimes even 50s on a routine basis. It doesn't allow us to use much higher PEEP. So I actually think it's not even that when we do experience the rare case of not pneumothorax, but we're seeing 1 or 2 cases pneumomediastinum, which goes into the sub-Q air, which is obviously uncomfortable for the patient. But it's not even the high PEEPs where I would be very comfortable saying we're using lower PEEPs generally than we typically would because the compliance limits our tidal volumes and our higher PEEPs.
Yeah, we've
Thank you.
Same experience with that, and we've also run into the problem. Well, it's not a problem, but we use permissive hypercapnia a fair amount so that we can minimize
Right.
what we're doing, and they also have fairly high dead space, some of them, which contributes to that problem. Sure.
And one of the viewers had a question regarding the role of steroids. I think this question is for you, Sugandhi. They wanted to know if you had any idea if steroids were used in any of the patients that you presented. It's mainly from a pathology standpoint. They want to know if there's, and what stage can you give the steroids?
Difficult. It's a difficult question for me, but from my knowledge, all the patients we had at that time, steroids were not started. These were autopsies done during March.
Right.
But again, I have some experience with transplant pathology, and I have seen some endothelial injury like this, and many times like antibody mediated reaction, the endothelium looks a little bit less swollen in these patients after treatment when we have those protocol biopsies. So if at all I can say there will be improvement with the endothelial swelling and therefore indirectly reducing the porosity of the endothelial cells.
Sure. Thank you. Thank you. This question is for Dr. Howard regarding ventilator splitters. Any experience at your center?
You know, I watched that very keenly. I believe the folks at Columbia, if I'm not mistaken, have already put out some papers on this. I watched this very interested early on, especially from New York and the catastrophe that they had. And then I was feeling pretty good. Okay, this is not going to be necessary. We have not used it yet, but honestly, we're actually, I'm very anxious about the fact that we're having to actually entertain the idea based on the trends that we're seeing in Houston the past week or two, that we may get to that point. I mean, we're starting to really stretch the beds. The ventilators are doing okay because the proportions of patients in the ICU for this second surge is actually lower, which I think is interesting and probably deserves an hour of discussion some other time. But I literally, it is on my reading list to go back and read these journals and these articles because I've got to figure this out because I think we very well could in this area be in a situation where we're having to resort to such extreme measures. So we haven't used it yet, but I'm definitely, it's in my learning box for sure.
Yeah, we were worried about that for a while too. We were fortunate not to run out of critical care ventilators for people who really needed them, and we did supplement with V60s and non-invasive type ventilators for the less ill patients. But early on, I thought it would be better to spend my time trying to get more ventilators than trying to design a splitter. When you think about the complexities of having different people with different respiratory system mechanics changing over time and trying to keep them relatively sterile or separate from each other, I think it's a nightmare, especially if it went on for any duration of time.
Right.
Actually, I think it is more sexy to talk about it than really in reality.
Yeah, I agree entirely, Kay. It got some media attention.
Right.
Yeah.
Actually, MIT is coming up with a ventilator. It's an ambu bag, and they have these mechanized pressers which press the ambu bag, and they have this little setup of the assembly of the ventilator settings. So MIT is working on it, but it's not a split ventilator though. It's mainly if we need more ventilators, then what do we do? So that was the thought process, and MIT is working on that project currently.
I would just get a bunch of medical students for that one, Sarah.
Right. Right. I have two questions for Dr. Hill. One is regarding the droplet. You were talking about the aerosolization and the droplet particles, right? We think these virus particles are mainly first droplet and then maybe aerosolization. And the droplet falls off, it falls to the ground and everything else. So nebulizers, and as your slide also said, the NIPPV, those have this huge aerosolization distance spread. So the high flow, what is your thought process regarding the droplet versus the aerosolization in these COVID patients?
Well, it's interesting, and I didn't mention it, but there was a study that came out of University of Michigan. Ishawina was the first author, and it was on Medarex IV, early publication. But they were unable to detect aerosol above background when they put healthy volunteers on high flow. And we've been doing a project on aerosol with different AGPs in collaboration with the Lincoln Lab at MIT, with a group of aerosol scientists, the pros, and we've done that experiment, and we cannot find aerosol generation with high flow, even up to 60 liters a minute. And I never thought there would be much, because it's not an aerosolizer, it's a vaporizer, and the particles are much smaller than with the nebulizer or something like that. And what a lot of people are doing are putting surgical masks over the nasal interface with high flow. And I did show the effect of that in one of the slides, that you pretty much eliminate the plume when you do that. So we do that pretty routinely, but I do think the concern with high flow has been overblown. It is a very useful device, and we haven't used as many helmets as Dr. Howard has. Our therapists, are not that enamored, and we've got a handful that we've done it on. A significant number get claustrophobic and don't tolerate it well in our hands. And we do have a small group that failed at high flow and then succeeded on NIV, mainly people who were, do not intubate. So we tried it, and it actually does better than high flow. I think it's probably people who need more pressure. They have maybe somewhat stiffer lungs by that time, and they do better with it.
Right. One of the viewer had a question. IV glycopyrrolate, does it decrease the aerosolization?
I have no idea.
I thought it decreases the secretions, but does it decrease the aerosolization?
The problem is that these things, in people who have infectious stimulation of secretions, I don't think they work. They will have an effect on salivary production. And so maybe that could do something, but I'm not aware of anybody who's studied it in any way, and it would be entirely speculative. I doubt it would have a major effect.
I mean, if the cough is not suppressed, they will still cough and generate aerosol.
Right, exactly.
Right. And one more question. Viewers said they had high flow. They use the high flow humidified oxygen for morbidly obese and sleep apnea patients. They had good results with using the high flow
Yeah.
for those patient phenotypes.
Well, you know, we have failed with most of the people we start on non-invasive in our experience. You know, that's, I'm friends with Stefano Nava in Italy, and he tells me that they've succeeded 75% of the time, but I don't know how they define that. But obese people, if they're morbidly obese, they are tough to manage, whether they have COVID or not. And high flow can work in some of them, but as Dr. Howard mentioned, a lot of times they need a fair amount of PEEP to keep their lungs inflated, and it's hard to deliver that non-invasively, even with you know, an NIV system, let alone high flow. I don't know what your thoughts are on that, Chris, but I'd be interested.
I agree. As much as I love high flow, we've definitely not had 75% success rate. I'd probably put it more in the 40% range if I had to guess right now.
Yeah, I would 30 to 40 for us.
I would agree. I mean, we have been using a lot of self-proning in these patients. And it depends on how much they can motivate themselves to do that with high flow also.
Right, right.
And I also agree this, I was listening to the previous panel, this thing of having 80% mortality on ventilator, I think Governor Cuomo kind of spread that. We don't see that. I think our mortality has still been like between 20 and 30%. So I think that's something people are really afraid of, you know, because of the publicity. Okay.
Right. So I have one question for Dr. Sugandhi regarding the cardiovascular pathology, right? Have you seen anything other than, have you seen like myocarditis mainly?
We haven't seen myocarditis in our autopsy series, but I have heard of other people seeing like lymphocytic inflammation. But in our autopsy series, no, we don't have.
Not seen anything.
No.
One last question almost is, how do we mitigate the CO2 retention risk with helmet mask?
High flow, and I'm not kidding.
Okay.
When we set up the helmet with CPAP, we actually use a high flow system, and
Right.
we're giving 40 to 60 liters a minute, and actually it works better with 60. And then you just use a PEEP valve and you stick a filter on it, and it's a pretty good way of delivering CPAP. But you need those kinds of flow rates to eliminate the CO2 and also to adequately inflate the hood.
I just want to bring up something that's like in the screening of patients or giving them eligibility, for example, for ECMO or any of the advanced modes. I know that in Italy they were dropping the age cutoff, you know, from 60 to 55, and depending on how many patients they had. What has been your experience? I know that the cutoff here is 65 for ECMO.
65 what, Kay?
For ECMO, if you're over 65.
Age 65.
Yes.
Well, you know, we haven't used a lot of ECMO. We've probably used it in maybe 10 patients out of probably somewhere between 150, 200 that have been on ventilators. And we have not used it in aged patients. I don't think we've used a hard cutoff like 65. We've probably got into the 70s, but put anybody older than that on it.
Okay.
I really want to thank Dr. Hill. Actually, we really enjoyed the slides. I've not seen the slides before, to be honest with you. It was
Neither have
a set
I.
of slides. And Sugandhi, thank you so much for sharing all the pathology slides and the autopsy slides. I felt as though I went to a pathology class back to school. And Dr. Howard as well, thank you so much for discussing all the ventilatory strategies that they're using in your hospital. And Dr. Guntapalli, thank you so much for helping me in bringing this excellent panel of speakers together. Dr. Suresh Reddy and Dr. Seema Arora here. And we thank Dr. Curtis as well. Dr. Guntapalli, please let him know that we really enjoyed his talk.
He had to leave, yeah.
Yes, thank you. Thank you so much. And I want to thank Dr. Suresh Reddy, Dr. Seema Arora, and Dr. Lokesh Adara and Vijaya for helping us organize this session. Dr. Nick Hill would like to be an honorary member of PAPI. I want to take this opportunity to let the executive team know about that. So maybe we can make it happen in the following year.
Well, any club that would have me as a member, I would never want to belong to, but I would be honored.
Thank you. We will be humbled. We'll be humbled to have you as a member. We'll work on the bylaws. Dr. Arora, do you want to say anything? Please.
Yeah, thank you, Saras. That was an excellent webinar. And I would like to thank all the esteemed speakers, Dr. Nicholas Hill, Dr. Christopher Howard, Dr. Ronald Curtis, and Dr. Sugan.
Sorry to interrupt. We can hear the Indian music in the background.
I
Is it
know.
like Agra time?
Okay. All right. Anyway, I just wanted to thank everyone, and especially all the speakers and the moderators and